Hello. Hi. I wanted to start, I was thinking should I start this lecture? And since it's 15 minutes, it's difficult to get all your research and experience into 15 minutes, I thought of starting to showing these two X-rays and asking the questions. So which one of these implants you would like to be yours? Or to be your mother's? Did you answer for yourself? Okay, thank you for your kind attention. This will be the shortest lecture. Of course, we want bone stability. And in order to get that, I want to introduce to the concept which we developed together with our team. Zero bone loss concept is a combination of surgical and prosthetic steps you need to take in order to achieve this. To have bone stability, to even have no bone remodeling. Also, it's important to say that, of course, this is with different kind of implants, different designs, platform switching, no platform switching, tissue level. So this is our, things which could work for different kind of connections. I'm coming from not from US. I graduated in Kaunas University, finished my PhD studies, and I'm coming from Lithuania. And I guess I'm a winner here who made the longest distance, yeah? Probably. And we have only 3 million people living. But you might think that I always want to say that not quantity is important, but the quality is important. And when you think about this, I always, when I come to AS, I always want to show this, because it really says that what we talk about, quality is important. Another point I want to make, I'm a clinician, but just from the very beginning, I turned my clinical work into combination of science and the practice. Because you would say, why do we need science? Very good example, a paper in the Journal of Prosthetic Dentistry, which really describes cementation process of using rubber dam. And paper says, let's use it because then we get rid of the cement. What we did, we tested it with a scientific manner. We made a crown with occlusal opening. I sealed it with composite, we cemented. And when we removed the cement, and were able to take out of the crown, look what you see. Completely different, a lot of cement. That's why scientific clinical aspects are important. And you as the directors, imagine you invite the person who describes the technique and actually doesn't work. So concepts are based on publications and also a clinical book which I've just released. Now, this is the topic we will talk about bone remodeling and bone loss. So, look, majority of us actually accepted that, the bone loss is unavoidable. Probably to this, with this paper published many years ago saying that, look, bone loss is normal, 1.5 millimeters at the level of the implant neck, and you're fine. However, are you sure that the bone will stop? Maybe it will continue, and you will have situation like this, when you have to remove the implant because it's already perimplantitis. So of course, it's clear that the best treatment is prevention. And it's not necessary to have bone loss. You can have stability through all the treatment, from implant placement till the follow-up. We face different kind of reaction. We see remineralization with bone if all the criteria are satisfied. Now then, which factor is most important? Because as human beings, we want everything to be very simple. Okay, so which is the most important factor? Now let's look at this from implant design and biological point of view. What factors for implant design should play a role in development of bone stability? So of course, polished or machined presence or absence of the neck, or the micro gap. These things are important. And if you place the implant with a smooth part in the bone, you're gonna go like this. Small part means small remodeling, Big polished part means maybe loss of the implant. And this implant was lost just because the tissue level was placed too deep. Now, what about the microgap or connection between the abutment and the implant? We must look at it from 2 points of view. First of all, as a source of bacteria. All implants are contaminated, right? But of course, connection matters, stability, how stable the connection is, because then we have the possibility of getting this bacteria out. And we all know that implants have different kind of connections. For example, this is the section of more stable connection, which if we really believe that implant design is the most important factor, should not have bone loss. But look here. And the last X-ray here, it's not 10 years follow-up, it's just delivery X-ray, when you give the patient and the patient is going away. So of course, we must remember that there must be a biological factor here. And biological factors, there are numerous ones, of course, but our research has focused on vertical soft tissue thickness, the factor which was really forgotten for many years. And if we put all these together, vertical tissue thickness is here. It's very similar to attached tissues, however, still a little bit different. Why it's important? Because from there we have the development of biological width or a protective mechanism. And when you see at these two images, you see on one abutment you have clean zone and you have plaque zone. So clean zone is actually where you have soft tissue adherence. Of course, you have different scenarios. You have thin tissues and you have thick tissues. And the first study our research team has done already almost 10 years ago, we checked what's happening if you have thin tissues, 2 millimeters or less above the implant, and we found that if you have these thin tissues, you are losing bone. And otherwise, if you have thick tissues, look what's happening after 12 years. This is actually the patient from the first study we did. We have a good reaction of the bone. And we're not talking about bone loss. I don't really understand when we say that bone loss is inevitable. It's not true. There are concepts to follow and to have bone stability. You might ask, what about platform switching? How does it really react to the tissue thickness? Well, the same. Two implants, side-by-side, implant with platform switching, without platform switching. After 1 year follow-up, no difference in bone stability. It means that biology is as important as implant design. So I would say that this is the wrong question to ask, which factor is most important? Because when I receive this question, I completely understand that there is no in-depth knowledge of the problem. We must talk about how factors relate to each other. Because I look at it as a basket of apples. Each apple represents separate factor, but they work at the end of the day in the same time. So what do we do if we have thin tissues? Yeah, the question is, of course, we have the problem. How do we thicken the tissues? 4 methods to do: flattening of the bone, supressal implant placement, 10-pole technique, or vertical augmentations of the soft tissues, different things. Let me just touch a little bit about this one, supressal implant placement. Because the idea is that when you place implants subcrestally, we are sacrificing the bone remodeling or the bone above the implant neck in order that biological width would form and you have longer or thicker tissues vertically. And still you have a very exciting X-ray. You have no bone loss, only bone remodeling. However, there is another step you can make. You can make, by using one abutment, one time philosophy for suprastally placed implants. If you attach stay-in base to suprastally placed implants, you can even avoid bone remodeling. And it's similarly done like there. You have implant placement. They are placed suprastally in order to accommodate tissue thickness. And then instead of placing healing abutment, we are placing this stay-in abutment. We are elevating our, let's say, new micro gap above the bone, and look what's happening with the bone. Bone staying from the implant placement to follow-up, completely not changing. So we are now in the middle of clinical study, which we're doing, comparing healing abutment or implant level with stay-in abutment level restorations, and we see that both X-rays look great. I mean, here and here, but with this, you can even avoid bone remodeling above the implant neck. So bone doesn't even change above the neck of the implant. Well, in the beginning I said, of course, this is the surgical part. You know, when you do the surgery, you place the implant, you select the position of implant according to the design. That's only the first step you take. And that's what I like, because it's integration of both concepts together, surgery and prosthetics. So from prosthetical point of view, we have, again, different factors. High of tie base, zirconia, cement or screw retained restorations, emergence profile. Of course, different things, but again, do not make a mistake. If there are a lot of factors, does not mean that we cannot control them. It's possible to do that. Now let me talk a little bit about cement screw retained selection. The speaker before me just elegantly told about this. Again, let me share with you one of my cases to finally answer the question, so which is better, cement or screw retained? So this case was treated 2009. And for 10 years, patient was okay. Suddenly, after 10 years, the patient came, we made an X-ray, 2009, 2013, and here you have 2018, perimplantitis. Wow, exactly. 10 years successful story, suddenly so bad. What happened? I mean, what changed? So what we did, we screwed out, we drilled through, we took off the crown with the abutment, just like I showed before. And this is how semen remnants staying for 10 years in mouth look like. So for 9 years, it stays without any problems. Suddenly, for some reason, it may develop perimplantitis. Now, the same patient, to be even more clear, in the lower jaw, we placed an implant, we stored screw retained. Of course, there's nothing, how to say, aesthetic about this. But you know, I don't care, because look at the bone stability. The bone is stable, the same patient, cement or screw retained. So here is the choice we made. Here is what we think of how to choose between these two things. And of course, with several results, you must stop using stock abutments, go, if we're talking about cementation, to individualized abutments, which clearly should have clearly supragingival margin. Only in those cases, it's really possible to remove semen remnants and to avoid this thing which I just showed you. And just before the end, another factor from prosthetic point of view, which is, again, very important, is what kind of material we're making for our restorations. Because we all know we have adherence and plaque zone. So the ideal material would give us the adhesion when you see the gluing of the tissues to the surface of the abutment. Now, glazed materials do not work. With time, we develop recession, bleeding, and other things. And you can have food remnants instead of the soft tissues. Now, zirconia restorations, if they are really polished smoothly enough, can develop this adhesion. And when you follow up things like that, you can change the structure of the zirconia from the rough, which comes from the manufacturer, to the very ultra smooth, which you receive from the lab. And look what kind of things it does. Delivery after some years, you see the tissues are adapting and creeping up further. 10 years follow-up, beautiful tissues around zirconia restorations. Now, sometimes this is 8 years follow-up. Look what happened with the tissues tissues are really growing into the polished zirconia, and indeed this is really, really important. And when you have a good environment, thick tissues and zirconia, you can really have this remineralization of the bone or good structure of the bone. So I'll finish up with the, I think, most important slide of my lecture. Single most important factor is for research, no single most important factor in our clinical practice. Thank you very much.